When the pandemic hit, the World Health Organization told us to keep 2 meters apart to remain safe.
It can never happen. Look how tiny our houses are. We barely have space to pass through.
In slum areas like this, it's unavoidable to be crowded.
This case in a slum in the Philippines reveals a bigger truth. Well-intentioned health solutions often fail if they do not resonate with lived realities. For decades, global health has sought to improve lives through programs, policies, and best practices. Yet, time and again, these interventions fall short once they reach the communities they are meant to serve. Why do we keep struggling with such unfit interventions? Many interventions are designed far away, in donor countries with strong health systems, then dropped into poorer countries where poverty, overstretched services, and limited infrastructure create vastly different realities. This top-down approach, sometimes called waterfall implementation, has been criticized for overlooking the social, cultural, and political conditions that shape health. Take clinical guidelines, for example. They're seen as a cornerstone of global health leadership. But the end users of the clinical guidelines are rarely involved in designing them. Experts often say they should be adapted locally, yet most countries with limited resources simply don't have the time, training, or means to do so. These are my colleagues. Back in 2014, as newly graduated doctors, they found themselves in a crowded maternity hospital in Zanzibar, Tanzania. The wards were full, the pressure was constant, and every day they witnessed the struggles of healthcare workers and women giving birth under difficult conditions.
There was this painful pattern where some women received too little and too late care, and at times that had heartbreaking consequences. And at the same time, other women, they received care too soon and too much, like unnecessary cesarean sections, which also could have devastating consequences unnecessarily. And altogether, it drained a lot of hospital resources.
Statistics later showed that in Tanzania, women in cities were more likely to lose their babies at birth than women in the countryside, despite nearly all women in cities giving birth in hospitals.
Every day, there were up to 50 women who came to give birth at our hospital, and it was overwhelming for me. I remember seeing this WHO guideline in a cupboard in our office, and I also remember thinking to myself, was this really made for me?
If health workers are to follow the WHO recommendations for routine surveillance during labor, it would take them 110 minutes of care for each woman every 4 hours, which means one health worker can only look after 2 women at a time. But in reality, each staff member at this hospital was responsible for 4 women in childbirth and a number of other responsibilities.
It's actually a quite common scenario at these congested urban maternity units, for instance in East Africa, that clinical guidelines, for instance from the World Health Organization, they're just so far from fitting the reality there.
When I met Nana, we decided to create small pocket guidelines for our colleagues to help them take care of women during labor. We wanted these guidelines to fit the local reality in terms of resources and as well as the situation in Zanzibar.
We thought in the beginning that this would be quick and easy, but realizing how far existing clinical guidelines were from the reality, it became a much more complex and time-consuming adaptation process.
We realized that this is not something that we could do by ourselves, just the 2 of us, and definitely not in a few evenings either.
the team began running several co-creation sessions, bringing in experts to make sure the recommendations in the booklet represented best possible, safe, and evidence-based care for such busy maternity units. What started as a small, unplanned initiative soon became the PartoMa project, a research project now grown over 10 years, all rooted in a real need at the front line.
The engagement of myself and my colleagues in the co-creation process of the guidelines was really meaningful. It made the guidelines feel like something of our own and something that was not imposed on us.
After the co-created guidelines were introduced through regular training seminars, the team began to see promising improvements in quality of care and survival at birth.
We were really surprised because we experienced a really high demand of the pocket guidelines. We were always in shortages because staff at the hospital, as well as outside the hospital at the facilities in Zanzibar, really wanted to have a copy of their own, and they also wanted to attend the seminars.
This success encouraged the PartoMa project to expand and scale up co-creation of clinical guidelines for childbirth in 5 of the busiest maternity hospitals in Tanzania. And just like in Zanzibar, the co-creation process also led to remarkable improvements. PartoMa's experience shows what can happen when end users are not just consulted, but truly engaged in defining the need for the project and as co-creators.
We need to make sure that their lived experiences shape future research, policies, clinical practice in ways that match their needs, especially in low-resource settings.
But at the same time, working in low-resource settings means the co-creation process requires significantly more time, resources, and flexibility in order to genuinely create effective health solutions.
It demands negotiating and agreeing and disagreeing and a lot of listening to make this work, and that's how co-creation really is.
Co-creating guidelines with healthcare providers and different stakeholders is not easy. However, it's definitely worth it. We can see the impact of the PartoMa project, which has now grown and has spread to different parts of Tanzania as well as in Ethiopia, and it has also inspired other projects.
Health solutions that ignore the lived realities of the people who really have to live with the solutions, they will often fail. And when we co-create with these people carrying the highest burdens and the highest challenges, we have a chance to make real impactful solutions. And that can really drive cost-efficient healthcare.